Hello, you're all very welcome to this event today on death, dying, and bereavement during COVID-19. And we're going to focus on wave 3 issues and responses. I'd also like to give a big welcome to our two speakers today. We have Irene Murphy from Cork, and we also have Niamh Finucane from Dublin. The event today is going to focus on those issues for social workers working with the dying and bereaved during wave 3. And we're also going to consider the legacy issues for social workers in other services who will in the future be responding to the needs of those bereaved now. Today is also a really good example of how the social work profession has been so innovative, creative, resourceful, and responsive when it comes to times of crisis, and a really clear example of our ability as a profession to adapt and to move quickly. Social workers across the country have created solutions to develop contact and connection with clients, to meet their needs, to deliver safe and effective services, and to do their utmost to keep clients safe and supported as far as possible. I think this event also demonstrates how social work is both an academic discipline as well as a practice-based profession. And our presenters today are going to share knowledge informed by evidence, but also knowledge generated through social work practice here in Ireland. First up, we're going to hear from Irene, and then we're going to hand over to Niamh before having about 15 minutes for some questions and answers. What I would ask you to do during the presentations is to type any questions that you might have into the Q&A section, and we will come to them then at the end of the presentations today. If you have any comments or feedback, please do let us know by typing them into the chat section. I don't know if you've had any time already to have a little look around the app, but at this online platform that we're in right now, you might like to have a look at the attendees to see who else is here. If you like, you can send them a direct message yourself if there's someone you'd like to chat with, connect with, or get in touch with. You'll also have an opportunity to view the information about the speakers who are here today as well. So please do take a bit of time to have a look around. I'm going to introduce Irene now, and then we're going to go over to her presentation. So I'll just say a little bit about Irene, and Irene, if you want to add some more, tell us a bit more about yourself, feel free. Irene is Director of Bereavement and Family Support Service at Marymount Hospice in Cork. She began her career working in maternity and paediatric settings, where one of the central aspects of her role was working with families who experienced stillbirth and neonatal death. Her current post is in a specialist palliative care setting where she has worked for 22 years. So I'm going to hand over to Irene now.
Thank you. Thanks, Cliona. Good afternoon, everybody. This is a slightly strange experience because I can't see any of you, so I'm talking to my own screen, really. So thank you for the invitation, Cliona, to talk. And myself and Niamh are going to talk today a little bit about social work grief and COVID-19. And we're both members of the Hospice and Palliative Care Social Work Group that has been going now for about 20 years. But really what we want to talk about today is about social work and social work in COVID. And we happened to be people who work in situations where we meet people with life-limiting illness and who are coming to end of life and bereavement. But actually, this is relevant, I think, to all of us, okay? So we're going to talk a little bit about our contribution as a profession to the situation that we find ourselves in now. We're going to talk a little bit about loss, grief and bereavement. We're going to talk about the pandemic as a challenge to us, but also as an opportunity. We have created opportunities, and we might mention a little bit about self-care, and it won't necessarily be in any strict order. So I suppose we have found ourselves in the last while in an unprecedented situation on a global scale. You know, it's had international, national, social, economic, personal, and organizational challenges. And it's the kind of thing we never imagined could happen, but here we are. And we're responding as a discipline within a society and within organizations, struggling with that whole business of public health regulations and how to deliver care. And we're trying to deliver care in a situation where uncertainty and constant change, it's the only constant actually, uncertainty, because COVID has created challenges for the way healthcare is delivered before and after the death and into bereavement. And a very nice document actually published by Tavistock in the UK at the end of last year talked a little bit, and it's about social work, and talks a little bit about on a personal level, our own basic needs as people, our basic need for security, safety, income, social contact, all have been also threatened and disrupted, which can leave us feeling helpless, fearful, and anxious, right? So we're trying to manage risk in a new way for clients and colleagues and for our organizations. We're trying to manage our own health needs and concerns and the needs of our own families. And when I say families, I'm talking about the people we live with, the older generation, the younger generation. And it generates levels of fears and anxiety of a kind that really isn't normal. It's not usual for us. It's not a personal crisis. It's a societal crisis. So if you like, for us as social workers, reflective practice, an opportunity to reflect within supervision and within teams has never been so important, right? Because we need support, we need supervision, we need our own sense of connectedness, empathy for one another, and information, and real-time information in a situation that kept changing right over the last 12 months. And it's a little bit about self-care, about pacing, breaking the task down into manageable pieces and setting limits on what we can do. And if you like, one of the things we've learned as social workers, I think, is that flexible practices have now become the norm. Adapting and being flexible, and our crisis intervention training and strategies have come to the fore. Okay. And as we try to bring these core social work values and principles forward, one of the things I found actually working here in COVID, and I had this discussion with colleagues of different disciplines, and one of the things we've all agreed of, actually it made us focus more sharply than ever on the issue of what is my job? What are my core values and principles? What is the task? What is the thing I can bring and contribute to this situation? So how we do our jobs is very different, but actually the core values and aims are actually fundamentally the same. I mean, that's the thing that I have learned, and I'll talk a little bit more about that. And it's a time as well where we became very clear here in Cork that it's important that we avoid the situation where others define our role. We know what it is we do. We know what we can offer. So it's very important that we own our skills and our contribution, and also very important to be visible in your agency, to come forward and ask, what is it we can do? How can we help? How can we contribute to the team? And that actually has been a very interesting experience for us here too in Cork. Now, support before death. Okay, so we're meeting people, and you in your various agencies are meeting people as well, where maybe there's somebody with a life-limiting illness, and we'll work with them before death. And I suppose the question is, well, what do we need to know? And if you like, theories of bereavement have emerged very much from a psychoanalytic tradition. If you go back to Freud, Lindemann, and people like that, right up through the decades, and it has actually been very medicalized. You know, grief is something that could become complex, needs treatment, and it has been very focused on the intrapersonal, what I call interpersonal, just the person, as if in some way this person dropped out of the sky and landed here today. And actually that very individualized approach, right, with the other expectations that came out of work, we'll say from Worden and Elizabeth Kubler-Ross and Bowlby and Colin Murray Parks, about there's kind of necessary stages to go through. And if we can only successfully navigate these stages, we will in some way achieve closure or recovery, right? What we now know, and we're now much clearer about, actually, grief is a profoundly situated social experience. Okay, it has a context, it has a history, it has a journey, it has people, it has networks and relationships all around. So we now know that the bereaved people who've experienced a loss, they seek meaning, and they seek meaning in personal circumstances, in familial relationships, and in the broader community, and from within the culture. Okay, and Robert Niermeyer has written very extensively on that whole notion of meaning. And we now, of course, recognize the value of narrative in the construction of meaning. And that was something Tony Walter brought to this from a sociological point of view. It's important that people have an opportunity to tell the story, tell their story, what happened to them, and a little bit about their experience. And if you like, this kind of broader view of grief as an interpersonal experience and not just an intrapersonal experience, it's entirely consistent with the systemic approach in which social work practice is embedded. We are fundamentally systemic in our view. So this greater appreciation of grief that we have now is actually very consistent with social work training, values, and practice. And I think that's something I'd like people maybe to hold on to from today, because I've heard people say, well, as social workers, we don't deal with bereavement. We absolutely do, because we're systemically trained and we now appreciate that whole grief and loss situation as very much embedded in systems. Okay, and we are an attachment-based profession. Okay, attachment is such a fundamental in our training. It's systemic in its focus, the individual in context at all sorts of levels. And in particular, social work, if you like, locates at that interface between an individual and society. Okay, we mediate, advocate, integrate, support, communicate, regulate. You know, we work at the interface of the individual and society. And in healthcare, which is my background here, we're working at the interface between the individual and family and the healthcare systems of which they're now part. So social work and system, I don't know where I got this graphic actually, and I'm sorry now I can't acknowledge it, but I came across it some time ago. This family that we're now working with or trying to provide a service for, that family is situated very much within a family system. And, you know, the Murphys and McCarthys have their ways of doing things, their beliefs, their values, their ideas of what's appropriate and inappropriate. There is a religious system, possibly. There's a community around them, and that community might well be an asset-based community, a resource for them. There's an educational system where they have children and young people. There's a social policy context, okay, where people, you know, the health services they're offered and the income supports they're offered come out of a particular social policy aspect. The justice system, a lot of our migrant workers are very much engaged with the justice system in terms of work permits, residency, rights, direct provision, which is going to be the next great scandal. It just needs another 10 years. The legal system, guardianship, access to children, custody, marriage, not marriage, the economic system, financial system, you get the drift, okay? And of course, now my slides have just stopped. Why is that? Oh, here it is. Okay, and of course, within the medical system, our families then have to navigate all kinds of different systems in different hospitals, different care centres, and that's for one person with one illness and staff with all kinds of responsibilities. So they have oncologists, radiation oncologists, surgeons, endocrinologists, palliative care specialists, physios, social workers, OTs, speech and language, etc., etc. Okay. So pre-death care, what do we need to know? Okay, so if we want to have an evidence-informed practice, what we need to do is go back and have a look at what does the research tell us, right? So empirical studies have been very much focused on identifying and asking the question, can we identify factors that exist before the death? They might be personal factors or circumstantial factors that might be linked to a poor outcome afterwards for the surviving relatives. So in other words, can we make a link between people who struggle with grief and some identifiable factors or issues beforehand? And the reason we would want to be able to do that would be maybe with the view to maybe influencing beforehand and having some sort of influence on how people might do afterwards, okay? So in palliative care, but actually within any sort of specialty within social work, the kind of insights we gain from empirical studies help us to design the care for the family before the death. Okay, it's information we try to integrate into our practice, so we might be able to influence the risk of complicated grief later. And of course, when we're talking about end of life in this presentation, we're talking about end of life care during COVID and end of life care where the person's death happens as a result of COVID. Because even where the death is not itself directly COVID related, it's happening during COVID times, COVID restrictions, and the experience is not too different. So we see the patient in the context of his or her family, and we try to offer strategic support to the patient and family. And we try to focus on family strengths and resources, as well as looking for vulnerabilities that might be pre-existing or that are COVID related, okay? And I think one of the things I just want to mention here, particularly all the systems we're engaged with ourselves, other care organizations, community services, they're all services under pressure because of COVID. So I think we need to be sensitive and respectful when we hear reports of people's experiences with other services. And just be respectful of the difficulties some of our colleagues elsewhere are experiencing, and just hear people's experiences without necessarily joining in the critique. So we hope what we do is maybe preventive for the family. We can't change what's going to happen, but we try to have an influence on how it might unfold. The National Clinical Programme for Palliative Care in Ireland, and I'm not going to dwell on this, but actually while it's a very busy slide, it's actually very comprehensive and it's worth having a look at. And I think you'll have access to the presentation afterwards. So it's worth having a look at some of the strategies and issues that are raised before death. So if we ask, who are the people likely to experience a complicated grief in the future? Or what are the personal factors, or what are the situational factors beforehand that we might influence? Well, what we now know is that people who lose a child, and when I say child, a child of any age, you can lose an adult child of 50 when you're in your 80s yourself. Loss of a child, Elizabeth Lobb has highlighted that from her systematic review. Spousal loss at a young age seems to be something that we should be alert to. History of multiple losses and multiple life struggles. You know, just because somebody in the family is unwell doesn't mean that all the other things don't happen as well. Lack of preparedness. Lack of preparedness is coming through more and more, particularly in the more substantial recent studies, which are based on large cohort populations. Lack of preparedness seems to be staring us in the face. High levels of carer burden before death, high levels of pre-death distress and depressive symptoms. We need to be alert to this. Family conflict, and that's David Kassane's work. Financial distress and poverty, which is something that multiple studies have identified as being implicated in less satisfactory outcomes and lower levels of educational attainment. So I'm just conscious of time now, so I'm going as fast as I can. Risk factors and implications for the pre-death care. We've always asked in palliative care, who has been carrying a heavy burden of care for a long time? Okay. Now, of course, in red, then I'm putting a COVID tag onto that. And the burden of care might have been additionally impacted by lack of community supports, or by the fact that people are choosing to remain at home for as long as possible because of visiting restrictions in hospitals, hospices and nursing homes. So actually we're seeing significant burdens of care with people staying at home as long as they can. We have always asked who seems to be particularly distressed or depressed in the lead up to death. Our notions of anticipatory grief have changed actually. What we need to be thinking about is a significant distress or depression before death. And of course, with COVID, has social isolation proved to be an additional factor with the lack of contact and support from friends and family and neighbours? And are there mental health concerns? Has anybody else in the family contracted COVID? So who's carrying extra burdens or other losses? Are there other people in the family needing care? Are people trying to homeschool as well as looking after the older generation? Is there an increase in risk of domestic violence, excessive alcohol intake, adult children returning to the family home? That's proving to be a mixed blessing for some families. And we've always asked the question, do the family realize the seriousness of this illness? And do all the family members, or are there people being shielded actually to their cost? And we need to explore a family's understanding of what is actually happening and why. So we need to assess gaps in their level of understanding and what we know they need to know. Is there a gap? Is there somebody being left out? Are children, vulnerable adults being excluded? And we need to very much come together with our colleagues from the MDT. And of course, we may well find ourselves having to address concerns about the route of transmission. Is somebody being blamed for bringing COVID into this house, into this nursing home, into this wherever? Socioeconomic disadvantage has always been our concern. Has COVID impacted on employment and income stream? And do social circumstances make, like inadequate housing, make self-isolation and cocooning very difficult, or making care at home very difficult? And are family members able to manage being together at this time, coming to end of life? A lot of families can't. They can't be together. They don't necessarily have been getting on very well in the last 20 years. They're certainly not going to do it now. And COVID has added fatigue, and tension has added to that. So the other thing we need to talk about is pre-death, because the evidence tells us this, is about concerns being expressed by the family about the kind of care that was given, or the treatment that was given or not given. And there might be ambivalence and conflict around that. And actually, as a team, we need to talk to families about this. We need to address it as best we can. And we also know that people will struggle afterwards where they perceive that family members received aggressive and inappropriate treatments or unsatisfactory treatments. What can we do to help there? Are there heightened levels of anxiety because of the ongoing nature of the pandemic and because of the wave 3 circumstances where we're seeing very upsetting data from hospitals? So assessment in collaboration with the family is very much consistent with our social work values around, diversity, looking at their unique strengths, their resources, their vulnerabilities, and communication with the family and with the team, and a communication of partnership. That's also one of our core values as social workers, identifying strengths and resources and focusing on empowerment. And one of the things, and this is Amanda Casey's piece about social work as a profession that values communication and connection. And we value communication and connection to support well-being with families. So with visiting district restrictions, our ability to facilitate communication by whatever means has become a key activity for us, enabling communication via Zoom, Skype, WhatsApp, Microsoft Teams, anything, FaceTime, whatever we've been doing. If you'd said to me 12 months ago, we would do this and actually we would have some good outcomes with it, I would have said absolutely not. But actually, it's much more important that we come past those reservations and see, can we facilitate contact, communication, saying goodbye, presence. Okay.
everybody. Just unfortunately, we're experiencing some technical problems at the moment. So we have lost Cleena, who is facilitating. So we're just waiting for her to log back on, and we'll get back to Irene's presentation as soon as we can. So I know the holding slide says the next presentation, but actually we'll continue with Irene's in a moment. So apologies for any delay, and we'll be back to you as soon as we can. Thank you.
Hi everybody, sorry about that. We had a technical problem and I have no idea what it was or how it was solved. But anyway, look, pre-death care in COVID, right? It's about focusing on how we provide a service and, with good ethical practice. And we value communication to support well-being generally as a discipline. And with the visiting restrictions, that business of communicating, connecting people with their relatives, with who they are fundamentally as people has become a key activity for all team members. But I think particularly for us as social workers, we've taken a lead in this. And we know that enabling family and patient communication, even if it's virtual, that clear communication, right, facilitates relatives to say goodbye. Now, that seems a very strange thing to say now. We would never have said it 12 months ago, but actually we have made it work. I have done a sort of a rolling Zoom call for a family in the UK whose relative was dying here with us in Cork. And they were able to talk to her as she was dying. They read little pieces to her. They played music for her, because their thing was she did not want to die alone. They couldn't travel, but she didn't die alone. They were very much present to her. So we must become, good at technology. We have no choice about that. And we now have to have very personal conversations on Zoom, Teams, Attend Anywhere, WhatsApp, and challenging conversations. But again, it is part of our skill set, I think, and I think we can bring that very much to the team. It does raise issues about confidentiality, equity, best practice, and working around the issues that we have to think about. But I think we have no choice but to make this work. But always remember, of course, when we're talking about connecting patients and families, one size does not fit all. Okay? Some families and patients are very happy with it. They can work it, but it's not natural in our practice. And we have to respect individual preference and consider confidentiality, particularly when people need assistance to partake. Somebody has maybe to stay with them to help them manage the technology. And sometimes too, when families make requests for connection and patients are struggling with it virtually, we have to ask, for whose benefit are we doing this? And certainly some of our patients who are happy to use the phone found the video calls quite intrusive and uncomfortable. We have used playlists of music, rolling photographs or physical photographs. For some people, they've been happy mementos. For other people, of course, the risk is that you bounce into the next patient with this great idea that this person enjoyed seeing these photographs. I do the same next door. For them, maybe it was a painful reminder of their loss. And maybe they find some of it as really intrusive on their privacy. They like to keep their lives separately. So virtual connection between team and family, of course, it raises issues. Does everyone have access to technology? How do we cross time zones? And our focus is on preparedness, making sure people understand what's happening. If they have questions, that they ask them then. And multiple connectivity. So we have people having family get-togethers on Zoom. They can be a virtual presence for somebody, even at end of life. And we have to manage expectations about what is possible also. Okay, now advocacy is a kind of a tricky one. With restricted visits, we can facilitate visits when people come to end of life. The question is, of course, is that the best time for the end of life visit to happen, when somebody is breathing their last, or should it be when they're more competent? And a 2017 study, which predates COVID, found that actually presence at the death was not something that tipped people over into a less good grief experience. It was actually opportunities to have meaningful conversations. That was the key. And we need to think about that a little bit when we're advocating for our patients, okay? And we need to be aware of language. We need to be able to say to people, and actually there's a reference at the end of this to a paper by Kellerman, an American social worker. It's a very nice, it's a link. And she says, look, be aware of language. We need to be able to say to people, look, this is not how you imagined it would be. This is not how we would want it to be for you. So how can we go about sharing time and memories and legacy? Maybe we need to record messages for people. Can patients dictate a note? Maybe there's ways we can create a presence even if you're physically distant. Can you tell me about John as a person, Mary as a person? And we need to think about creative ways to reminisce, to share feelings, create a nice environment. Do they have pictures of home? How can we provide comfort? Okay. And reinforcing memorials and memories. these things travel over time. So helping people to appreciate and find value in these things rather than seeing them as a kind of a second best. This is what we have to put up with. Help people to appreciate and to value memorials and memories. And when travel is allowed at a later stage, maybe then they can use these memories as part of their honouring the legacy. Okay, and psychoeducation around ritual, around memory, around funeral, all of those things are something we can contribute in a very concrete way. So we need to listen also for the unique responses of patients, their worries, their fears, their anxieties, and we need to give honest information and align expectations with it, right? So language, so maybe rather than talk about people being in isolation as in some way a restriction, we need to talk about keeping somebody safe, keeping other family members safe. So we need to look for opportunities, and we need to think a little bit about Robert Niemeyer's point about meaning. Can we help people to develop a sense of meaning in their whole experience? Okay, so that's a whistle stop from me, and Niamh is going to pick it up. And again, apologies for the break in the transmission. So Niamh is going to talk a little bit about after the death. All right, thank you.
Hello, everybody. I'm very sorry about the technical difficulties that we're having here at the moment. I'm really glad that I'm not responsible for sorting it all out. Just to go back to Irene's presentation, I think something that I was really struck by was the importance of reflective practice within teams and within supervision in terms of trying to make sense out of what it is that we're experiencing, what we're learning, what we're seeing, and figuring out how best to respond. I was also particularly struck about Irene's point about there being such clarity about what is my job, what I do as a social worker, what is my value and the difference that I make within this organization. And I really welcomed the point about not allowing others to define our role. That I think has been a theme for social workers in many settings, as psychologists or nurses or other health and social care professions step into spaces that were traditionally occupied by social work. I found it really heartening to hear that clarity about the difference that social work made has really come to the fore. The other point that I was very struck by was grief as a situated and profoundly social experience. I suppose many interventions have become quite individualized, and within healthcare and other settings, the need to measure and count and evaluate has sometimes created a push towards more individual interventions. So I think we're going to go over to Niamh now. And I'd just like to introduce Niamh, who's the coordinator of the Social Work and Bereavement Services in St. Francis Hospice in Raheny in Dublin. Niamh has been there for 14 years, initially working as a senior social worker on both the community palliative care teams and also in the inpatient unit. Niamh's work is probably familiar to many of you because she has worked on a national level. And I also wanted to draw your attention to a document both Niamh and Irene have worked on and authored that's in the COVID resources section of isw.ie. So I'm going to hand over to Niamh now for the second part of our lunchtime event. Thank you, Niamh.
Thanks very much, Cliona. I suppose I work, as Cliona said, for St. Francis Hospice Dublin, so that covers both Raheny and Blanchardstown, so really the whole of the north side of Dublin. And myself and Irene are part of the Hospice and Palliative Care Social Workers Group. So we're a group of approximately 50 odd, maybe 60 social workers nationally who work in the area. Some people are very much based in specialist palliative care. Other people are in roles where palliative care is part of their job. So if anybody out there who isn't already part of the group thinks, goodness, I'd like to be connected with that group, you can contact either of us and join us. So as a group, we come together nationally and look at issues that are going on in palliative care, and particularly from the social work perspective, and what we might need to do. And so we're presenting on behalf of that group today. So I suppose Irene did sort of the pre-death focus, and I'm going to do some of the focus for after somebody dies. And really just beginning with, sorry, Mike, yeah, I don't know what happened there. Just coming back to some of what Irene said, it is about coming back to basics. What do we already know as social workers? What do we already do in our job, and how do we use that? And if we have a good foundation in that, that's going to help us to be able to build on when there's further complexities that may arise as a result of COVID. And one thing we know about grief is that it is a really normal response. It's a natural response to a significant loss, and not just a death. So although most of this presentation is going to focus on grief following a death, it's important that we recognize it as a response to any significant loss, because during the time of COVID, there have been many losses experienced by people. Loss of connectedness, loss of celebrations together, loss of opportunities to say goodbye, loss of other opportunities that might have arisen in life. People who plan to travel and can't, people who, wanted to get married and have postponed. So there's so many other losses that are there, people who've lost their job, people who life is just looking very different for. And I suppose it's remembering that grief affects us on a very holistic level. So it affects how we think, how we feel, how we are physically, and therefore our sense of meaning and how we behave. And so if we hold all that in our minds as we think about the next little while, it's important because we will meet people not just where somebody has died or somebody is dying, but also people who are grieving other losses. And we need to just take that into account as we think about how do we best support them now. And is some of their responses or the reactions a reflection of some of that? And is that a way that we might be able to help them? So it's also remembering that grief is a process and it's dynamic. So it's something that changes over time. Grief is individual to each and every person. So they often describe it as individual as a fingerprint, but yet there's so many themes that are common across all aspects of grief and loss that we can talk about it. But it's remembering that it does happen differently for different people and in relation to different losses. So somebody might have one type of death this week and have experienced a different death a few months ago, and their responses can be similar, but also quite different, because as we'll go on to see, there's a number of factors that come into that. As Irene already highlighted, grief occurs in a social context. So where do people situate themselves? Where are they living? Who's around them? What else is going on? What's the culture? And really, as social work, we're looking to think about how can we enhance people's skills and abilities for managing the loss and learning to live with grief, because grief isn't something that we can take away. And in our society, very often there are aspects of the world that do try and shut it down, hide it away, not think about it. And we're often talking about grief literacy. And I think COVID has really challenged us as a country to think about that. Even on the news, people tend to pass away and not die. We tend to try and soften it and move away from it. And yet there's another conversation beginning around a shared remembrance and being able to mark, because we haven't been able to do it in the typical way. So I think it's something that's often oscillates and can be quite different at different times. What I wanted to do was just place things in a bit of a context before going in more detail, because this is, I suppose, how we frame, how we think about grief and loss very normally. So in Australia a number of years ago, Samir Aoun and her colleagues did a study on people in the population of a particular part of Australia where people died, and she followed up with their relatives. And they died from any type of death. They may not have been involved in palliative care. So this wasn't palliative care specific. And previously they had been thinking that about 60% of people would be low risk, about 30% moderate, and 10% high risk in terms of their responses in bereavement. And actually their research bore out that those figures were actually quite accurate. And so really what that tells us is that for about 60% of people, they're actually going to do okay if we can give them support of friends and family and good quality information about grief. So they may not need much more than that. And in the modern life, there's a lot of talk about people needing counselling and needing support after something has happened. And we just need to remember and temper it with the evidence that's there to say, actually, not everybody does. And sometimes we can do more harm providing support when people don't need it. So most people will do well once we give them that good quality information. Some will need additional supports. And then others may need a higher level of support again, including a small number who need specialised care and our mental health services. So when we're looking at bereavement support, we should be looking at a tiered approach. So nationally in Ireland, we have what's called the Adult Bereavement Care Pyramid, and this was developed in the last year or so. And what it does, and people can go and look at it in their own time, because I know there's a lot of information on this slide, is it talks to us about what needs might people have when they're grieving. Therefore, what type of service or support would they need? And thirdly, what knowledge and skills do those services and supports need? So the green one would be about 60% of people. The yellow and the orange one are the next 30 to 35%, and only 5 to 10% are going to need that higher level support that's on the top. And if you look at the pyramid, we also have that circle that tells us we need to look at the circumstances around the death, and we need to look at the social networks that people have, and we need to take account of time. And that being not just time since the death, but maybe also what stage of life our people are at. So they're all things to think about. And again, just because people may not be aware, there's a similar pyramid that exists for children. And it's just mentioning children. This presentation is primarily focusing on adults, but part of supporting adults is also helping them to be able to best support children. So I'm just putting that there to mention that exists as well. So I suppose, what do we already know about grief and loss, and what helps us when we're working in bereavement in terms of going forward? And really, we know that grief responses vary hugely, and different approaches benefit different people. So no one size fits all, and there isn't just one way to do it. And that's really important, because sometimes services, you know, want people to do particular things, and it may not work for that person. It may have worked really well for somebody else. So we need to really think about what we're asking and what we expect of people. You know, that there are different expressions, you know, that grief is different for different people. Ken Doka talked to us about an idea of a continuum between instrumental grievers and intuitive grievers. So intuitive grievers are those who will express their grief by being able to be very emotional, being able to talk to us about how they're feeling and whatnot. Whereas instrumental grievers are people who find that incredibly difficult to do, and actually they cope by doing. So they're the people who might get out and do the memorial activities or different things. And so if you think of that as a continuum, most of us are somewhere along it and might have a bit of both aspects rather than it being either. But if we ask the instrumental griever, how are you feeling? They're not going to be able to answer that, and actually we could end up being less helpful to them. So that's when we need to think about things being different. And equally for intuitive grievers, they might find doing things more difficult. So if we understand some of these concepts, it helps us think about what supports might this person need right now or might best fit for them. People like Gilbert also talk to us about the fact that when we think about grief, and Cliona mentioned, you know, that so much is on an individual level, we actually need to be thinking about it in the context of a family. But when we talk about a family, although there's a family grief that occurs, individuals within that family can be at different points or have different coping styles. So that's really important. And we know from research that grief impacts on relationships, and relationships affect the grief. So that's really important. And there are some other work out there in relation to family approaches that can help with some of that. One of the issues that Ken Doak also talked to us about was what he called disenfranchised grief, whereby griefs may not be recognised or unacknowledged. And I think in COVID times, there's certainly lots of griefs that people may have experienced. And there's a danger of a hierarchy developing whereby we focus on, you know, people who died of COVID as being the worst grief, and people who died of other deaths not being, you know, seen as challenging or as difficult. And I don't think anybody intends for that to happen, but certainly I think it changes and charges a context sometimes, whether it's a sudden or planned death, whether it was traumatic or not, and all those factors. But also other disenfranchised griefs are sometimes more hidden ones, like miscarriages or other losses, like not being able to travel to see family at a distance. And people are saying, but can't you see them virtually? And so it's denying some of the losses that are there for people. So we just need to be alert to it. And I suppose from what we've seen, Aaron would have talked also about just compassionate communities and the value of social connection. And I think that's some of the national conversations we're having about a national remembrance for people. So, I mean, this is really very much a whistle-stop tour of some of the theories that are around in relation to grief, but I think it's just helpful as a way of framing some of what we talk about. Because when we're looking at it, we want to think about people adjusting rather than accepting. You know, that grief is about psychosocial transitions. What is it that's changed? How is it that we need to adapt? And what's going to happen? Linda Machin has done a lot of work to talk to us about the fact that people can have a lot of resilience as well as vulnerabilities. And so we need to look at both for people, not just one or the other. And there's a danger that sometimes we only focus on the struggles or what's difficult, and we forget to look at the other side too. And there's a danger in doing that we would pathologize people, or that we would miss out on some of the things that help people cope. Strobe and Schutt have a really helpful model, which is called a dual process model. And it's that idea that people need to be oscillating between acknowledging their loss, but also looking at restoration. So integrating and accommodating the losses. But they also developed the model further to talk about it being in background of having other life stresses and challenges. So there's a potential for overload for people in grief. And that overload may come not so much from the death itself, but actually the fact of the context in which it's happening. So in the context of a pandemic, that's very much one of the issues for people, because the other life stresses that can be going on are extremely heightened and are much more present than they might be. That can be financial losses because everybody in the house has lost their job. It can be some of the just fears and worries around what's going on in the pandemic, about my health, about others' health. So the potential for overload is greater, and we just need to be alert to it. sometimes what's helpful for people is coming back and asking them a bit about, who it was who died and fleshing out that person, particularly when maybe we haven't had the opportunities to go to funerals and maybe listen to eulogies and do things the way we normally might do. In grief, Bob Niemeyer is one of the big people who talks a lot about meaning making, and there's some evidence for that being helpful, but we need to just be careful that that doesn't fit for all people. And sometimes actually that's the real struggle that people have. They can't see a sense of this, they can't make any meaning out of it, and it's something we need to be careful not to push too much. It's acknowledging the relation factors in grief, and then just that idea of a continuing bond. How do we acknowledge that the person has died, but at the same time remain connected to them? So overall, what we're trying to think about is how do we help people focus on aspects of narrative that are going to help them both now and in the months after death. And that might be helping people to reframe some of their experience. So if somebody has had to go into a place of care, that they didn't give up on them, they didn't forget them, that actually part of what they did is they continued to care for them in different ways. Now that was always a challenge for people, or could be a challenge for people when somebody's gone into a place of care, but it can be even more so in COVID because actually maybe they didn't get in to see their relative. Maybe the relative that went into the nursing home, they haven't seen for months. So it's now much harder to think about them caring for and supporting and being involved in their connection. So it's one of the things that people now be made more challenged about following the death than they would have been previously. And Irene talked about a lot of the research that's there before death to show us that preparedness for death can very much influence or have positive outcome and bereavement outcomes. So the more people expect it and it's anticipated, the better their outcomes are likely to be. However, deaths due to COVID are much more likely to be experienced as unexpected. Things have changed fast, people have died more suddenly, or part of what helps with preparedness is seeing the person change, seeing the fact that they're different today to how they were yesterday. And if we get in to visit people regularly, we get to see that. But if we're not, and it's a few minutes on a phone or through a screen, maybe we're not getting the other messages that show us that somebody's less well. So we don't notice that actually they're not getting out of bed because they were in bed when they made the phone call 2 weeks ago as well. So we're not getting other cues that help fill in these gaps for us around preparedness. So when we're talking to people before someone dies, it's really important that we are pulling out for them some of those changes and making them as explicit as possible, that we're using the narrative to paint the picture, because the other cues aren't there for them. What we also know is that we need to look after somebody dies at the severity of the response after death. And there's more and more research coming out to say that, if there's a high severity of response in that acute phase straight after death, that can be predictive of more difficulties later on. So it's one of the things when we're thinking about who might need help. And if we go back to that 60-30-10, that's one of the predictors as to why you might follow up with somebody as opposed to another person. And again, just mentioning, because the research tells us this is important to hold in the back of our mind, it's also that family is key to providing support to bereaved children, and that the functioning of the surviving parent is a strong predictor of adjustment for children. So again, there's rationale as to why we would also be thinking about, if there's children involved, how is the other parent getting on, particularly if the other parent dies, and what supports might they need. So when we think about all this, we're very much looking at adaptation and grief. So after death, there's changes that people need to make. And like Irene, I did the black for normal processes and the red just to show some of the challenges that might now be there because of COVID. So after death, people have to do very practical things. They have to register a death. They have to organize maybe finances and other things. And so really they can benefit from lots of tangible and practical help and support. And that's one of the indicators that if people get that, that can help them to do well later on. If we don't give them some guidance, they're more likely to run into trouble. There's a lot of change processes as a result of COVID. So even if you registered your relative's death 2 years ago, you don't do it the same way now, because with COVID, you can't go into the office you went into and it just doesn't happen the way it does. And so things keep changing, and it's changed a lot. So we as professionals have a big responsibility to try and continue to educate and inform people about what's different and what's helpful. The other thing around tangible and practical supports is it may be the neighbours who cooked a dinner and dropped it in. It may have been that they took the kids for a while. It may have been some other hands-on support that they offered. And COVID has really challenged the opportunities that are there for people to do that in a way that they normally would, because everybody's concerned about too much contact or the risk of getting the virus or different things. So it is putting people at a slightly heightened risk, some of those tangible supports. So again, how can we help fill that gap? We know that funerals are part of processing, part of that ritual, part of trying to get our head around what's going on. And so we may need to help people think, how are they going to manage rituals when they have to happen differently? So we may need to help suggest things, give people information if we're involved around a time of death. We also, into the future, may need to talk to people around some of that. Do they need a new ritual? Is there something else they can do? And I think when we go back 12 months, people thought, well, in 3 months' time or in 6 months' time or somebody's birthday or anniversary, we'll celebrate their life then. And actually, here we are 12 months later in COVID, and that opportunity has come and gone as well. So, we need to maybe be tempering people's expectations and trying to make it realistic and look at what they can do rather than what they can't do. In grief, people's safety and security is always challenged. So something has really changed in my world. I'm no longer who I was. I now have to relearn my world and figure out how to do things. That's heightened now because of COVID, because already there can be that hierarchy of needs and that altered sense of risk. So in the hierarchy of needs, now I'm just focused on, and I suppose last March, April, we were all focused on, getting the shopping in and making sure we're okay and staying away from everybody and whatnot. And as it's gone on, how do we deal with the risks that are there from COVID? How is our safety and security? And sometimes it causes an increased anxiety. Now, for some people, it has actually given them an opportunity to withdraw from the world in a very safe way. And actually, for some bereaved people, it's increased their sense of safety and security. Somebody said to me, Niamh, I don't have to keep saying no to all these invites because there's no invites coming because nobody's doing anything. So actually, COVID for that person gave them an increased sense of safety and security and allowed them, they felt, to process their grief. And I think that's a really important thing, is that we don't catastrophize people's response to grief in the context of COVID. Absolutely, there are heightened risk factors. There's things we really need to be thinking about, but we need not to add to the catastrophizing that could occur through some of the narratives that are developing. We need to stick with the normalizing and the validation and the acknowledgement and the regular work we do, while also acknowledging some increased risk. And that's important. So as we adapt to grief, normally there's always a renegotiation of family relationships. And one of the things about this is that if we're not having family contact as normal, because we live in different counties or we're in different bubbles or whatever the concept might be, then actually that might be a more challenging thing to do. And again, renegotiating family relationships is seen as having one of the biggest influences on functioning, and that therefore can have one of the biggest influences on adaptation. So when it's not happening, and COVID has really challenged how it can happen, that can be more problematic into the future. And we can see elements of delayed grief occurring. Social support is a really important concept in grief. And it's not just whether or not people have or haven't got it, it's their perception of it and their experience of it. So are they feeling cared for? And it's not that social support buffers the impact of bereavement. There's very mixed evidence about that. But there is strong evidence to say that when social support is experienced or perceived as helpful, that it is one of the strongest determinants of positive outcomes in bereavement. So we really need to look at this in COVID, because how do we continue social supports when the normal social support structures are significantly reduced, altered, or absent? And there is an increase in isolation, there is an increase in loneliness, and these then are more risk factors. So we really need to encourage people to look at the ways in which they can connect, the ways that they can enhance any sort of social connectedness that they have, be it virtual. So even if you think of on posts sent around, the postcards, trying to get people to write cards to each other, they're all important ways of just saying hello, acknowledging, feeling connected and helping people reconnect. Because one of the very normal things in grief is helping people to reconnect with their social supports after death. And again, it's a process over a period. Re-engaging with activities is also an important part of adaptation in grief, and this happens over time. It has an important effect for people in terms of their health functioning and their well-being. And again, this is something that just isn't so possible in grief. At the moment, level 5, all of these things tend to be closed. And so for some people, then this is where they're feeling that they're not getting to reintegrate, to reorientate themselves, and to readjust to the world, because actually part of the world has been suspended because of COVID. And I think people without, a death are struggling with some of this. So in the context of a death, it can be an added challenge. As I said, for other people, it's a relief that they've been able to step out almost unnoticed, and that they'll re-emerge at a time that feels okay, as everybody else is. And so it may be a way for some people to support them in grief. But all of those things are also part of what gives structure and routine. And in grief, when our world is turned upside down, we really strive predictability. What's going to happen day in, day out. And so if it's changed because we're working from home, or we've lost our job, or we were minding the grandkids and now we can no longer see them, our routines are gone and our structures are gone. So it is a big challenge for people in COVID context. So again, just thinking about, are there ways in which we can help people look at things to structure their day, even if it's very basic general things. They have a function. That's what the function is about. And so if you can think of what's underneath or behind it, some of what we're doing are very basic, simple things, but if we do them well, they can really support people very effectively. People can have lots of memories after somebody dies, and very often in the immediate aftermath of a death, those memories are about the diagnosis, the change, how somebody was just before they died. And it's a really normal process in grief that we go back on that, but that's what we think about first. But that over time, we process those memories, we revisit them somewhat, and then they're able to settle and we can remember the person in better times. However, when somebody's death is either from a traumatic event, or there were some difficult symptoms, or there were other aspects that made that difficult, if those memories are becoming intrusive, we need to just be alert to that being a sign of trauma. And deaths from COVID may have been more traumatic. Not all of them, but some of them will have been. And it's just important that we think about, this is now 3 months down the line. They're talking as much about this as they were 3 months ago. There's no shift. We need to be alert to, do they need a more intensive support around the trauma element? So all of this is about adaptation. How do I adapt my world that's changed because the person that I care about has died? My world's already upside down. But it's very disorientating when the rest of the world is upside down as well. So the whole world has gone upside down because of COVID. We're probably more anchored now than we were 12 months ago in some ways. But again, it's just that it can, for some people, it can be helpful. For other people, it's compounded their changes. So it's just thinking about that. There are cognitive factors that act as barriers to grief adaptation, and ultimately we are looking for adaptation to be able to live with loss, and it's just being alert to them, which is avoidance, the intrusive memories, and the social disconnection. So we want to encourage people to look at self-care, exercise, and to care for themselves. Again, that's, if we can get people to care for themselves and tend to their own health, that's one of the bigger predictors of doing well. However, if the health systems are altered and some of our normal care is being cancelled, and if people are avoiding health systems because they're concerned about the COVID risk, that may actually compound some of their challenges in grief, and we need to be alert to it. And just, that idea of technology, we can use different methods. As Irene said 12 months ago, the idea of doing some of what we've done in the last 12 months by Zoom and other things was unimaginable. And yet here we all are today, able to have this contact, and it does offer something. And it's not the same, but it does do an awful lot. And so I heard it described as support at a warm distance. So trying to have that connection. I just thought that was a lovely descriptor for us to hold in our heads. I'm really conscious we're out of time, and I just want to leave time for questions. So on the slides, there are just 2 slides about possible bereavement risk factors. So people can go back to those, and their risk factors that are there that heighten it. They're not definitive. So just because somebody's child dies doesn't mean they're automatically going to have more difficult grief, but they're just being alert that these are possible. And it's not just one or the other. Sometimes it's the combination they occur within, or within the context of other parts of people's lives. So just people can go back and look at that in their own time. So overall then, what can help is that we need to make sure we give information and support around the time of death and in the immediate acute phase of grief, and trying to provide it in a range of formats, so spoken, written, visual. Ensure that people have information and supports they need to complete the associated formal processes and procedures, like registering the death, so the tangible supports. We need to seek ways to increase and maximise connectedness. We need to emphasise exercise, routine and self-care. And by exercise, it can be a simple thing like doing a lap at the garden. I'm not talking about going out and doing a 5K walk. We know for people in grief, their energy is in their boots and they struggle with these things. But actually just the difference of walking to the gate and back is already just beginning to help shift something. We do need to constantly be assessing the bereavement risk, looking at where isolation fits, where fear is, and being alert to safeguarding. And this has been a whistle-stop tour, but safeguarding can be an issue in terms of how do we make sure that people, if they're living with domestic violence, if they're in situations whereby they're a vulnerable adult, that those issues need to be attended to. And we need to enable people to access support. So we need to give them information about what's available and how to access it and refer them for support if needed. So there are 2 slides of references that cover both Irene's presentation and my own. We just did the one lot of references together. And then there's a link to both the document that we spoke about that Cliona said on the website, and then there's our contact details. So thank you, everybody.
Thank you, Niamh. We've been getting lots of comments in both about Irene's presentation and Niamh's presentation as well. Yeah, just comments about the systemic based profession, drawing a focus onto that, the distinction between instrumental and intuitive grief as well was found very helpful. And I think that public health slide that you put up, Niamh, the 60, 30, 10 was just really helpful in breaking down the different needs groups, I suppose, that are there. We have just one question. If anybody has a question, now is your time to get it in. We've just a few minutes left. Hi, I was wondering if you could recommend any specific recent research materials on supporting children and in turn their parents around impending death of a sibling. The sibling has complex needs, fragile health. I wonder, would you be able to point in the direction of any particular resources or research?
Do you want to take that, Niamh, or will I pick it up?
If you've got something off the top of your head, I direct people towards the Irish Childhood Bereavement Network site, but that's okay. A lot of that is more post-death. I think Ireland probably has more up-to-date ones off the top of her head.
I suppose a couple of things. If somebody would like to email afterwards, right, just email me and we'll send a response, because one of my colleagues does a lot of work on this kind of anticipating the death of a sibling. And there are some nice materials actually out there to support parents. So by all means, send an email and we'll point somebody in the right direction. I'm very happy to do so actually, because it's something that social workers should be doing proactively. And we also compile some of our own material. We put stuff together ourselves here all the time. So if somebody'd like to email, I'll forward it to a colleague who will respond.
I actually had a question for Niamh around when you were talking about preparing for death, and you spoke about how the constraints around COVID means sometimes that we can be missing cues that help prepare for a loved one's death in the absence of visiting and having contact. And I just wonder, have you got suggestions or ideas around that?
I think with preparedness, this could be an issue in regular times as well, that sometimes people don't see changes. So if you come in to visit and the patient perks up for that period of time and they're always in the bed, you're not seeing some of the changes, like the fact that actually they could walk the corridor 2 weeks ago, now they can only walk from the door to the bed, you know. So I think as healthcare professionals, we have a responsibility to ensure that we make explicit some of the changes that are there, you know, that we're helping people to understand the significance of them. But sometimes we use phrases that to us make sense, and we know that that means that at the next stage or that things have progressed. But actually, for family members, they haven't joined the dots because sometimes they don't even know the dots are there. So I think we have a big responsibility to make it explicit, to talk about, do you notice any change? Do you see things, you know, to tease it out with people. And sometimes then they can begin to name what they see. And I think the more we can do that proactively, the more that people are already acknowledging that something's different. Because sometimes even somebody who's been here in the hospice, we meet them in bereavement and they say, God, I was so shocked they died. I wasn't expecting it. And, you know, when we really look back on it, we're thinking, goodness, they came in for end of life care. They were here for 3 weeks. They changed quite a bit. You know, how can this person come and be having this conversation? So it is about perception. And I think in that, we need not to assume what people understand. So constantly checking out with people what their understandings are and helping to bridge gaps. I don't know if there's something else you'd add, Irene.
No, I think that's about the size of it. And I suppose sometimes too, when families are caring at home, right, they're doing shifts. You know, somebody does Monday, Tuesday, somebody else does Wednesday, Thursday. They pass each other. And they actually get very little opportunity sometimes to sit down and process what's going on, compare notes, talk among themselves. And sometimes actually that's something we can facilitate. Get them to come together and talk to each other, actually. A lot of the time when we're having a family meeting, it's as much about getting them talking to each other as getting them to talk to the team. You know, and I think COVID, for some families, because people were furloughed, they were able to help out a lot with the care, but for an awful lot of families, they weren't. They just weren't, and they were very cut off from the experience. And then you have family members advocating for dad to be cared for at home. They weren't at home trying to do the care with inadequate resources, you know. So helping families to kind of mediate that sort of tension is sometimes something that I think social work is good at and can see the ordinary human, you know, foibles and frailties around those issues. And we help to people, you know, we help to people to articulate those. You know, I spoke to a family lately on Zoom. One said, no, we won't take him home. Actually, lady who just lost her nerve. She said, this is too much. We won't manage. And somebody else in the family saying, absolutely, we will. Come on, we'll get him home. Get an ambulance quick. And just talking through their worries and concerns and then reflecting it back to them that actually they were both talking about the man in the bed. They both were coming from a position of care. They want the best for him. They were just articulating it a bit differently. You know, so that kind of communication skills approach is something we have. And we're able to hold difference. We can hold tension sometimes, and we can hold uncertainty. That's what we often bring to the team, and we manage it. Where sometimes our other colleagues want the problem to be solved. Whereas we can hold difference, we can hold uncertainty. Would that be correct, Niamh?
I think so, yeah. And I think the other point is that, you know, it's helping people as to what's their experience of it, because it may not be their brothers, their sisters, their mothers, you know, and to have that type of approach. And I suppose some of what we're also talking about in terms of grief and loss is that we might meet people not just where it's around death and dying, but the impact of loss in their lives as we come across them in other contexts. And, you know, that's why some of the theories and some of the other things are important for us to hold in our heads, because as social workers, I think we've a huge skill set around adaptation anyway, and that's important.
Yeah, and I think that is something that has come through so strongly in the past year for social work as a profession, both nationally and internationally. I think our profile has increased. I think there's increased clarity about what it is that we do well. And I've seen that come through really strongly in the presentation today, that connection and care piece that we do so well, the ability to hold uncertainty that you talked about, Irene. And then, of course, the systemic perspective that we bring to all of our work in whatever setting that we're in. Is there anything that you would like to add or to say before we close up today? I'm conscious it's 2:05 and we don't have any more questions at the moment.
I think grief and loss is part of so many aspects of social work. I think when it comes to death and dying, people can get fearful, either because they haven't been there before or because they feel out of their depth. And I suppose what we really tried to highlight was how much of the core social work ethos, values, skill set is around dealing with grief and loss in so many other ways, and then what extra layers might you need when it comes to death and dying piece. And sometimes recognizing, I suppose, the impact on self, because although we're healthcare professionals, we've lived through this pandemic as well, but also there's people that we both know, as do all of our colleagues, who wouldn't do our job in a fit because they just don't like the idea of being surrounded by death and dying, whereas we might struggle, think, gosh, I wouldn't do their area of work, so it's recognizing those our self-reflections on it, whether they're limitations or whatnot, and knowing that we can reach out to others for help and support as required, and that's always there.
And I'd like to leave you with the defining our role. That's for us to define. We need to come together in our own teams, in our own agencies, and we need to explain to people what it is we do and how we do it and why we do it. There's no point complaining that people don't understand how much we could bring. Actually, we just need to demonstrate it. We need to demonstrate our value, be proactive, and reach out. I think that's important.
But there's nothing really left for me to do except to extend a very big and heartfelt thank you to both of you for taking the time out of your really busy days and schedules to share this practice wisdom that has been generated through the work that you do. I very much appreciate it, and I know that everybody attending and people that will watch the video of this event in days and weeks to come will appreciate it themselves. Thank you very much.
Thanks for the opportunity, Lena.
And thank you for listening. Take care.
Bye.